So the next question, sort of a tricky one. Bat spit has no demonstrated usefulness to man.
It's got to be a lie.
Well, kind of a half-truth. And this is a study from this year, which is the diet study. So a fibrin-specific plasminogen activator named desmoteplase was trialed. Again, instead of using a time window for onset of stroke symptoms, they used diffusion-perfusion imaging, looking for a mismatch, so looking for evidence of an area of ongoing ischemia that wasn't receiving blood flow at the time. They randomized 104 patients, treated, again, in a larger time window of 3 to 9 hours after symptom onset. So none of these patients were eligible for IV-TPA. So the data there, the white bars being reperfusion and the black bars being a favorable clinical outcome. This was a dose escalation study, so looking to find the optimal dose. And as you see in the treatment groups there, marching up to the 125 dose, more favorable outcome compared to placebo on the right side. So recombinant bat spit looks like it may have a role. Let's skip that. The implications of this, which we've talked about a little bit, is, again, this use of tissue viability measures instead of time. Downsides to using an MRI up front to determine that tissue viability are the time it takes to get an MRI. You know, the patient gets shoved in a tube for a period of time and you may not have good access to them. Although we'll likely see a move towards CT perfusion imaging here in the near future. Advantages being that you can get a CT quickly, you can get a CT angiogram at the same time, and you can get a sense of tissue viability. And so with this big change really in our imaging capabilities, you have the results pretty quickly and you can really decide what to do with that patient up front. Another big change in neurology recently has been the advent of cool names for trials. Frequently sort of previously the purview of the cardiologist, but the clot bus study came out earlier this year. And this is interesting. This is 126 patients who were found to have a middle cerebral artery clot, so presented with a clot known in that vessel. All of them received TPA. They were randomized to continuous TCD, so transcranial duplex. So someone sat there sort of insenating, so sending an ultrasound at that clot for 2 hours. So not necessarily the job you'd want to have, but 2 hours sitting there with a probe. And they found, in looking at 2 endpoints, recanalization, so opening of the vessel, and clinical outcomes, they found the following. And here's an example of what that insemination, what that ultrasound image looks like. On the left side, there's a little flow, and as you move out beyond the time window of the initial event of receiving TPA and that 2 hours of getting the ultrasound, the signal, which was very low, indicating a blockage, moved almost to full recanalization, the far right being normal. So how did these patients do? This is percentage of patients with recanalization and percentage of patients without. So the control group being the bottom and the target group being above, that's up to 2 hours afterward. So really a significant difference in the amount of patients who opened up that vessel when they got TCD in addition to TPA. Functional outcomes. So again, this is this Rankin scale of how people did overall. The target group did much better than the control group, so the blue being, the dark blue being better outcomes, so shifted over to better functional outcomes. So not just a pretty picture, but these patients did better. So something else that's coming up, again another study this year, is of factor 7. And this is on a different front, so this is for intracranial hemorrhage. Patients excluded who had subarachnoid or other bleed, but typically the medical patient who had a hypertensive bleed or some other type of bleed. These patients were treated within 4 hours. They found improved function looking at decreased expansion of the clot overall. The number needed to treat was 5 to 7 to prevent 1 death or disability. So pretty significant changes. And a phase 3 trial is pending on this. This initial data out of New England Journal earlier in the year. And if you looked at the percent of survival, the top curves being better, and those are the patients who are treated with the factor 7. The downside to factor 7, as you might imagine, as I'm sure Don knows, is money. So this is not a cheap drug. And so we really want to make sure that there's a lot of efficacy. But for patients who present with intracranial hemorrhage, deep in the basal ganglia or other places where you wouldn't want to operate and they may not get benefit from surgery, stabilizing that plot with factor 7 may be a big deal. I think we'll see a lot of marketing around this, assuming the next study is positive, because you have to justify that cost. Hopefully they'll do a better job than this group who was selling sarsaparilla. So you have to choose your abbreviations. Next case. 68-year-old patient presents with right-sided hemiplegia. Onset was 12 hours prior. Febrile, blood pressure 170/85. General physical examination was non-focal. The neurologic exam, as you can see there. The imaging, something ain't right. So let's go through the questions. Looks like this was an ischemic stroke in the anterior circulation. Onset was 12 hours prior, so really beyond the time window for any of the treatments we've talked about with the exception of aspirin. So what can you do? You know, is this a patient you just want to send home? Is there not a lot that you can do? Let's talk about a few things. Typically, one of the questions that comes up is, well, what do you do with this patient's blood pressure? A lot of us have seen this graph before, but it basically looks at how you control cerebral perfusion pressure and cerebral blood flow. You want to be on that flat part of this curve. Patients who are hypertensive have shifted that curve to the right, and you don't want to abruptly drop their blood pressure because they will lose that autoregulation of their cerebral blood flow. And so it's something that we think about. The typical answer you get overall with blood pressure management is, well, you don't want it to be too high, but at the same time, you probably shouldn't let it get too low. And so that's about as helpful as people get in general. For intracranial hemorrhage, the data appear to be pointing to you want to keep a systolic pressure less than 160, a MAP clearly less than 125, and you don't want to drop pressure quickly. So the slope of a drop in intracranial hemorrhage pressure treatment correlates with poor outcome. In ischemic stroke, there really isn't a lot of data, and so that's why that's sort of vague issue. In recent studies, they've looked at functional outcomes of patients based on their blood pressure and the timing of their blood pressure to improve. And what they found is that the patients who seem to have that persistently elevated blood pressure, I think we've all had patients who, they're hypertensive when they come in and it typically just kind of gets better on its own, or those patients who remain hypertensive. The patients who remain hypertensive tend to do less well. And maybe that's just a measure that that area of the brain still isn't getting any perfusion, and that there's an ischemic penumbra that remains at risk. So is there anything left that we can do? Well, one of the fundamental rules is there's no clinical condition I can't make worse. And so we really want to avoid complications. And that's about 50% of the mortality from stroke. That includes DVT, which we can prophylax well against. Includes aspiration pneumonia. That's why on the stroke pathway, everyone gets a swallow screen or swallow evaluation, every single patient, and UTI. So you want to avoid Foley catheters if you can. And if you recall on this patient's presentation, he was also febrile, so his temp was 38.5. General rule in stroke and ischemia is that heat is bad. You could argue ice isn't necessarily good, but heat is clearly bad. The reason being cerebral blood flow, some new kind of data, the marketers and product development is not far behind, which gets you big machines and fancy movies. But essentially what you can do is you can take a catheter, very simple triple lumen or femoral catheter, which is placed. They did not find evidence of DVT or a lot of complications from this, but the different methods of cooling the patient is that you have this catheter in place. One lead goes to a machine, another lead goes to a temperature measure, so a bladder temperature sensor, and you can run supercooled fluid in that sort of counter-current exchange model from that film, or you can just run it through those other catheters that you see there, and really tightly control the temperature of the patient, so you can bring them down fairly quickly. People say that being cooled from the inside is more comfortable than the outside. I don't know. Another thing to keep in mind is avoiding hyperglycemia. So we've seen this in the ICU data overall. Trying to keep a patient's glucose between 80 and 110 has a decrease in mortality, so very important. We're doing this throughout the hospital now. But data very similar in stroke. This curve being from intracranial hemorrhage, so conversion intracranial hemorrhage from ischemic stroke seems to be much more. So you get more of a risk of bleeding with hyperglycemia in ischemic stroke. So all these patients should have their sugars tightly controlled. So change gears again. What's coming up next in stroke treatment? Well, we have a nice private grant to improve our stroke care here. The move from JACO now is looking at certification of stroke centers. And so just as a lot of the organizations are looking at how we're doing disease by disease, we're going to be looking at that for stroke care too. So our outcomes will be monitored pretty closely. And JACO will be certifying centers, so we're going to apply for this. The implication being then that hospitals that are not certified won't get those patients. So the ambulance will drive by and go to one of the centers that are certified. Starting to see that trend nationally, and so something to keep in mind. You know, the idea, I think, is a good one. The things that they're looking at are these. This is real simple stuff and things that we should be doing for all of our stroke patients. So, you know, humor aside, I think it's the right thing to do because traditionally, we as physicians have not done a very good job measuring what we've done or being very strict about what we've done. So the next question, which I throw out there with a little bit of trepidation. So neurology is irrelevant, I'm biased. Let's call that one a lie. So Prove It is one of my favorite neurology articles. This is a survey of voter participation by cognitively impaired elderly patients. And so this is an article out of our neurology journal. And what they did is they took a dementia clinic and they surveyed these patients to figure out how many of them voted. What they found was that a very high percentage of the demented vote. And so it's really an interesting commentary. You can spin it however you want. But you can at least say that the demented are proportionately overrepresented in our electorate system. National study, I believe. So in conclusion, I think TIA overall is difficult to diagnose. It's relatively easy to treat. So you may argue about diagnosing it or not, but we've got some pretty good data about how you're going to treat these patients. In stroke, I find it useful at least to use an algorithmic approach. We have a number of diagnostic tools. There's a lot you can do. It's a matter of picking the appropriate one. You want to avoid complications. Again, 50% of the mortality for stroke. You want to initiate appropriate secondary prevention. And there's a lot of stuff coming down the pike here and a lot of new advances. I anticipate we'll see in the next couple of years, again, a big shift in the way we treat stroke patients, the aggression with which we treat them, and then the modalities that we have to treat them. This next thing for questions is an example of why you shouldn't leave your husband alone trying to figure out whether your son is left-handed or right-handed. Because you may find out that he's ambidextrous. So I think we have a few minutes for questions.
In this window of opportunity for TPA, when you treat them very early, how can you be sure that some of your good results aren't coming from treating TIAs?
You don't.
Okay.
Simply. It's nice to take credit for something that would have gotten better anyway.
Exactly.
And at the same time, you don't want to expose someone to risk for something that would get better anyway either. And so it's a valid point. I think what's clear is that a patient who comes in and seems to be improving is not someone you want to treat with TPA. So you don't want to expose them to that risk if they seem to be improving. The nature of stroke and what we know right now, given the good safety data overall for TPA, is it's appropriate to treat those people who have a significant deficit.
Second question. I don't think you talked about Plavix plus aspirin, aspirin plus Plavix. I don't think you made any.
Based in Ballard, but I also have an office in Bellevue, and I concentrate mostly on skin cancer and Mohs surgery. I was asked to talk about skin cancer and chose non-melanoma skin cancers because they are by far more common, fortunately, than melanomas. And actually, since this slide was made, it's actually 1.3 million new cases of non-melanoma skin cancer are diagnosed in this country each year. And it's estimated that children born in the 1990s have about a 1 out of 3 chance of getting a non-melanoma skin cancer in the course of their lifetime in North America. And actually, most of those cases, or at least many of them, present to you guys in the primary care setting rather than to dermatologists. So people blame President Kennedy because he was the first to show up at the inauguration without wearing the traditional top hat. He didn't like wearing hats. People stopped wearing hats. Among his various addictions, he really enjoyed the sun and got tan as much as possible. He didn't live long enough to get a basal cell, but this guy did. And about 20 years ago, he got a basal cell on his nose and brought to public awareness the importance of skin cancer and the sun. And so I wanted to focus mostly on basal cells, since that's what I see most of the time. But squamous cells behave very similarly. Just talk about the etiologies, some clinical and histologic features, how they spread, how they move through the skin, and then conclude with the variety of treatment modalities that are available, and particularly one that I do most. Now, the sun, by far, is the most common etiology for basal cells, squamous cells, and melanoma. It's not the amount of sun that you got yesterday or last summer, but the cumulative exposure. Usually the first 20 years we get the most sun exposure before we go to medical school and never see the sun again. But also it's the recreational exposure, going out on the lakes and the intermittent blasts of sun that we may not have predicted we'd get. Even with cloud covering, a fair amount of ultraviolet light can trickle through. And a considerable amount of DNA damage can occur, alterations in P53 tumor suppressor genes. There are photodimers that are caused by ultraviolet light, and a general suppression of the immune system locally. That is the most common etiology, but it's not the only etiology. There are some other important ones to at least have in the back of your mind. X-ray treatment used to be a fairly standard approach to acne in the 1940s and 50s, or to tinea infections of the scalp. There's a great latency period, maybe 20 to 30 years before basal cells and squamous cells develop, but now we're seeing the results of that. And if patients have a history, and it's worth asking them about it, you'll see that they'll have almost a field effect of just a series of basal cells across the chest or the face, and you can't quite explain it. It's usually there is some sort of X-ray exposure. There are some rare, fortunately, genetic conditions that predispose people to skin cancers. Basal cell Amoeba syndrome is one, xeroderma pigmentosa, where people cannot repair the DNA damage that's caused by ultraviolet light in a greatly accelerated rate of skin cancer. But in burn scars, other forms of trauma, basal cells, and particularly squamous cells, can develop. Arsenic we don't see too much anymore. It used to be in well water. It was part of certain treatments for asthma, or disgruntled wives used to use it. But we don't see that, and there also is a latency period of a few decades before some of those cancers develop. But this is kind of a classic person that's going to get skin cancer. Midwestern farmer, considerable amount of sun exposure, hypopigmentation, a lot of photo damage. What you're seeing also are scars from previously excised basal cells and squamous cells. But you see someone like this, and it's starting to have very similar types of damage. A lot of the speckled hyperhypopigmentation, a few scars you see here from previously excised basal cells, squamous cells, and she also had melanoma on her nose. And she's 15 years old, and she has xeroderma pigmentosa, which, as I say, very rare and unfortunately deadly condition, because these people develop melanomas at a very early age, and that's usually what they end up succumbing to. The standard basal cell is usually completely asymptomatic. It may be something that the patient notices, or it may be something that you see on them, but it could bleed, scab, and that therefore come to someone's attention. The vast majority of them are in sun-exposed areas, head and neck, particularly the central face, the nose, the lips, the ears, the most common sites that we deal with. The onset is not necessarily the elderly population, actually middle-aged start to get these, although we are seeing that increasingly younger, and I've gone as young as 20, 21 years old without having another genetic condition associated with it. Certainly the advent of tanning beds and teenagers in tanning beds has accelerated that process. About 1 out of 3 people who have one basal cell may get another one if you follow them over a 5-year period. Not necessarily in the same place, it could be in any other place, mostly sun-exposed areas. So it's warranted to follow up with these patients. They should at least have a screening once or twice a year after their first basal cell. The classic clinical picture is the nodular variant, and the sort of textbook case of this curly papule with raised borders and telangiectasias coming across. This may eventually ulcerate and bleed or develop a scab. It may just look like a regular flesh-colored mole. But the standard place is a sun-exposed area, such as the nose. But there are other types to be aware of. The superficial variant is kind of tricky because it mimics so many other things. Somebody comes in with something like that, you're not necessarily thinking of a basal cell. In the right clinical context, this could be a contact dermatitis or something. If it is on the ear, you think of a nickel allergy, or a belt buckle area could certainly be. If it is on the scalp or an arm and somebody has a pet, you can think of a tinea infection. The key thing is it just doesn't respond to the regular therapies. It's worth putting them on something, either a topical steroid or a topical antifungal. It's certainly reasonable to do that as long as you see them back. And if a month later, the standard approaches, and there are very good steroids out there and there are very good antifungals, if nothing is working, then it probably is reasonable to do a biopsy, especially if they've had a history of sun exposure, to make sure it isn't this superficial variant. Because what happens is you can get, they just get away from you. They get a lot wider and spread. They're sort of an insidious variant of basal cells because they're often diagnosed after different treatments have failed. This is also, I think, a Midwestern farmer that had this on the back, didn't respond to antifungals or steroids. The aggressive growth pattern is the trickiest of all because it mimics really scar tissue. What you're looking at over here, see that central area is actually the biopsy scar. But beyond that is a kind of wider white plaque, and you can't really see it so much as feel it. There's different textures. And it's just impossible to really find too early. But it might bleed, or it might develop a persistent scab. And as a result, somebody eventually biopsies it, but it actually goes out to about here. And under the microscope, you can really see these kind of spiky root systems. They tend to be a lot wider than the other type. Pigmented is the least common that I see, and it's usually found people that have more pigmented skin. So Asian Americans, African Americans, Hispanics are more likely to present with this variant. Actually, it's very similar to the nodular pattern, because it has that kind of curly raised border. And usually these are biopsies to rule out more ominous melanomas, and then they come back incidentally as basal cells, but they act just like any other basal cells, just have pigmented. Basal cells traditionally expand out and keep insidiously smoldering along the surface and then infiltrate. We say that it's kind of like looking at a tree stump in a swamp, in the sense that you can see the top part, but you don't necessarily know where those roots go, and they can go beneath the skin further laterally and deeper than what may be clinically apparent. So they keep a hard surface and then skate along. They rarely go through bone or through cartilage, but they come up to it and then skate along the surface. Other areas besides cartilage and bone is the tarsal plate of the eyelid, or various fusion planes, embryonic fusion planes, where, say, the ear meets the scalp that can track along those areas, or in the medial canthus. And that's when they can be very tricky to eradicate, or along fascial planes, where different cosmetic units of the skin meet. And here's a gentleman with a kind of classic nodular pattern. It's already started to ulcerate in the center. This spot may have been there for 2 to 3 years at least, probably a little more. When you're looking at it, it would be reasonable, if you're trying to excise it, to take a margin of a few millimeters around it, and you would think that you would get it all. When this was actually tracked out to see where those roots were, the difficulty in this situation is is that you have several parts of the face that lead to this area.